My name is Ajay Kohli. I'm one of the faculty members in radiology and orthopedic surgery at UT Southwestern in Dallas, Texas. And I have the sincere privilege and honor to be invited to host this panel session along with these leading minds in musculoskeletal radiology, orthopedic imaging, and of course, AI. As you all know, AI is this new ubiquitous technology that really continues to have innovative developments over the course of years, months, weeks, and sometimes even days and hours. And it is up to us as folks within the field to see how we can implement it in new and exciting ways. And within the field of medical imaging and radiology, there's perhaps no bigger use case for AI than in the field of traumatology or emergency imaging. And that is what brings us to this panel today. And with that, I will begin introducing our panelists. So first off, we have Dr. Catherine Endriol. Catherine, would you like us to tell us a little bit something about yourself?
Sure. Hi, I'm in the Department of Radiology at Brigham Women's Hospital, Harvard Medical School, and I am the Director of Academic Research and Education at the Mass General Brigham Data Science Office. I did classical machine learning many, many years ago and now have come full circle to do machine learning and informatics.
Very cool, very cool. And that's the new name, Mass General Brigham, right? I know you guys change your names quite a bit, so got it. Yes. Wonderful.
Mass General Brigham.
Mass General Brigham, got it. All right. Our next panelist is Dr. Fritz, Jan Fritz, coming in from NYU. Dr. Fritz, Jan, you want to tell us something about yourself?
Yeah, hi, everyone. Yeah, I'm the director of musculoskeletal radiology, the chief at NYU. We're right in Manhattan. We're a large academic section. We have over 30 MSK radiologists. I have been involved with machine learning from a image reconstruction and MR acquisition side. So we're trying to speed up MRI and harness the possibilities that deep learning is giving us. I also have, of course, tried disease detection algorithms as well.
Very cool, very cool. Well, pleasure to have you. Moving on to Dr. Jacob Visser from Erasmus. Jacob, you want to tell us a little bit something about yourself?
Sure. So my name is Jacob Visser. I'm a musculoskeletal radiologist, a health economist, and a clinical epidemiologist at the Erasmus Medical Center in Rotterdam in the Netherlands. I'm an assistant professor in value-based imaging AI, and my research basically focused on development, validation, implementation, and valuation of AI algorithm in radiology. I'm also the Chief Medical Information Officer at the hospital at Erasmus MC, heading the IT at the Department of Radiology, and recently I've been elected as the chair of the Scientific Committee of the European Society of Medical Imaging Informatics, and I'm also serving on an RSNA ACR steering committee for common data elements for quite some years, and I've been in the ESR value-based radiology subcommittee and also at the ESR eHealth and Informatics subcommittee.
Very cool, very cool. Welcome. And last and certainly not least, Dr. Daniel Fascia. Welcome joining us from the NHS. Please tell us a little bit something about yourself.
Hi, AJ. I'm Dan Fascia. I'm joining from Yorkshire in the United Kingdom. I'm a musculoskeletal radiologist as well, and also the regional clinical director of the Yorkshire Imaging Collaborative Network. So I'm in charge of 32 hospitals tasked with the network strategy for them, including a population-level AI strategy for a population of 2 million people over here. I'm also still an active dabbler in code, and so play around with lots of algorithms myself. But I guess the thing I'm most involved in these days is bringing AI solutions to operational use in the NHS in the UK.
Very cool, very cool. Such a diverse panel, lots of unique insights, and I'm very excited for the discussion today. So I'm going to begin with Dr. Fritz. So Jan, you lead this large-scale academic center with particularly in MSK and trauma imaging. So, and you have worked in the past with, a very unique case of MRI with, utilizing AI within MRI reconstructions, particularly, for orthopedic imaging, for imaging with hardware and trauma. If you were to take your lessons out to a much broader field of application of AI to all of X-rays that potentially come into the field, what do you see as a potential challenge? And do you think there actually is a need to implement AI in MSK radiographs?
Right. So, of all the musculoskeletal imaging studies we read, I think it's fair to say that radiographs is by far has the highest numbers. And that's the major challenge, right? So, the major challenge for us as trained MSK radiologists is not so much reading those and interpreting those, but it is to master the volume. And the volume has been ever increasing. Radiography is great. It's useful for a lot of applicator, detection processes, but it's also widely available and is considered one of the cheaper tests. So I think from my point of view, it is the volume and also the reimbursement is borderline low. So it's hard to make, from a radiology point of view, to make a living off radiographs. So this is what we're being tasked with. I think what is being talked about is accuracy. So, looking at, quality assessments and, what I'm not sure accuracy is the issue. The issue is more volume, timely reads, and not so much complexity of the cases.
I see. So taking that a step, even, sort of working backwards, right? So we have the solution and now moving it to actual implementation. I'm going to switch gears and actually go to the AI and implementation element of it. And this question is for Kathy. So Kathy, in your experience of implementing clinical AI, going from soup to nuts, what has been your experiences? What are some of the challenges you've faced in taking a new AI algorithm that you've developed within the lab and then implementing it out into the clinical world?
Sure, happy to talk about that. But first, maybe just to add to what Dr. Fritz just mentioned, I think around the accuracy, it may depend on whether you want the models to detect normal or abnormal, perhaps. And maybe these tools can be used as a triage tool for high volume places, or to be used as a tool in places where they don't have MSK expert radiologists to look at imaging. But there's a complex process, and people kind of hone in on the detection piece, which radiologists do quite well, except for the volume that they're dealing with, which is quite difficult. But the process really begins with, what is the clinical question? What are you trying to detect? And then defining that well, defining the cohort very well, such that the model actually is giving you a realistic response. If your data cohort on which you train the model is ill-defined, then your results are going to be less interpretable. And then you go ahead and build the model, and then you validate it on outside data as well, hopefully using different patient demographics included in your data set, including different imaging vendors and different protocols for imaging the exams, because that can impact the model. But then once you're ready to actually implement it clinically, you may want to do a couple of things. You may want to tune it for your local patient population if the distribution of your population is very different from the model, the training set that the model was developed on. We test in shadow mode first to make sure that it doesn't break anything, make sure that it's robust, that it works in our workflow. And then I think these tools are really only going to be useful, again, particularly around the issue of trying to combat the increasing volume, if these tools are implemented in the point of care technologies that the radiologists are using. So that means, if you're improving acquisition, maybe it's in the in the acquisition device, the smart device, and you're reducing time for MR scan. Or, oh, I love the cat. If you are doing interpretation, is it at the PACS workstation that you're using? Is it in your reporting tools, and so on? So I think those are very important pieces, and that's a more difficult piece because not everybody has the internal capabilities of adapting things for their local institution, and there are vendors that can help you do that. And then lastly, these models do drift based on a number of things, whether it's the patient population drift, whether it is the imaging modality that changes that may change the model, and so on. So you need to continuously monitor and make sure that they're continuing to operate in a reasonable fashion. So there's really a whole pipeline of things. And I would argue that you could use AI throughout the whole imaging chain, not just at interpretation, but use it as Dr. Fritz is at acquisition, maybe even at scheduling. I'm looking for no-shows, maybe even at improving the quality of the image. If there was motion, for example, in the imaging of the exam, let the technologist know that right away instead of when the patient is left the room and gone home. And then reporting assists and so on that we've done for some of our applications. So I think people should think more broadly about how to use these tools.
Definitely, and great points. I have to say though, Jan, this was a question of, this panel was based around X-rays and not CAT scans. So you brought your cat into the picture. Just saying, radiology joke. It's not very funny, so it's okay. I didn't expect many laughs there. Okay, but thank you for that great answer, Kathy. Lots of points that you discussed, and we could probably have like an hour, if not multiple hour discussion on so many of those critical components, right? Like training, drift, monitoring, and so on and so forth. But one key component that you did bring up was sort of the radiologist machine interaction or the radiologist AI interaction, and particularly, the human machine interface. And that's going to be a very critical component as we are implementing AI. So, question for Dan, as you implement and as you've built your own AI and built your own, technical user interfaces, how do you foresee the relationship between the radiologist and the AI and fracture detection algorithm? Like, what are the specific use cases? And, specifically and also generally, how does the radiologist interact with the AI and how does that change our workflow?
Yeah, AJ, I think maybe the radiologist is the wrong starting point here, because one thing I want to get out there is I'm not sure fracture detection AI is for us. I think it's for the front door of the hospital. I think it's for primary care, for emergency physicians, and specifically in the UK, the vast numbers of very junior doctors who are staffing these areas around the clock, who don't even have the detection powers of their senior trained colleagues, let alone those of an MSK radiologist. So I think that these user interfaces that you talk about, they are for all of these groups, and that's what makes it a real challenge in user interface design. I like things which harness what people know already, and therefore my preferred way to deploy AI solutions at the moment is to read the binary data out of the DICOM and to label the images in an easy to understand, sympathetic way, nice bounding boxes, arrows, clear labeling of fracture versus no fracture, or if it's not sure if it's just a lesion, then it just highlights that something needs looking at by a radiologist. And to not try and be too smart with its level of integration into multiple other hospital systems. Now, there are some benefits that you can get when you start integrating into the PACS reading list, for example. You can prioritize the reading of abnormals versus leaving the normals for a bit longer. But anyone who's tried those integrations, cross-vendor, cross-product, it's really challenging. And actually, DICOM query retrieve is quite straightforward. And so currently, my preferred way is to design good-looking secondary captures, because they actually get AI to anywhere that can display a DICOM image already. And that's most of our clinical areas that are using X-ray.
Very cool. I see. So you've looked at the whole gamut, particularly from training, particularly to, implementation, how you would put in the bounding boxes to actually, figure out where the pathology is and then kind of take it forward. No, that's great. And, if you were to take that even a step further, and if you're actually implementing this within a large use case in a hospital system, within a national healthcare system, this question is both for Jacob and Danielle, and especially you, Jacob, with your background in value imaging. What potential benefits do you see, from a value to cost perspective of implementation AI, of implementing AI in trauma imaging, and particularly MSK imaging? I'll have you, Jacob, begin.
Yeah, so as Daniel already mentioned, of course, it depends on the type of AI, but now we are talking about musculoskeletal AI. And I think a lot of those AI really benefits those who are outside of radiology, right? So it can help, for example, so imagine you do not have enough radiologists available, and the emerging physicians, they are not sure enough, or they do want to have a kind of conclusion from a radiologist or an algorithm. Then the algorithm output can be used to basically decide on the next steps within the healthcare process, right? So if you have, for example, a look at the emergency room, which is rather crowded also in our hospital and usually in a lot of other hospitals too, you could imagine that you can basically lower the turnaround time of patients within that emergency room. So it's important when talking about implementation of AI to not only have a look at the benefits for the radiologists, but and especially for MSK, I think that's the case, also have a look at the downstream benefits, the downstream effects to the in the healthcare chain. And this is important to mention because, a lot of the time, the AI applications are being bought by the radiology department. So that basically comes down to the fact that the costs are coming to radiology, whereas the benefits are going to other departments. And of course, it depends on the system that you are acting in, but it's important to consider when taking decisions on using and buying AI applications or not.
Definitely. You have to look at the whole system perspective, and particularly the downstream effects. And Dan, in your experience of implementing this within the NHS, what are some of the challenges that you've overcome, and how did you go about doing so?
I mean, some of those challenges that have just been described couldn't be more pertinent than in our National Health Service. We are a system with far too few radiologists, spread very thinly. We already have and have maxed out reporting radiographers doing plain film work. We already have and have pretty much maxed out teleradiology doing this for us. And so we desperately need workflow solutions that will help at the front door of the hospital to detect things like fractures so that patients can get more timely treatment. We also have a lot of virtualization of clinics going on since the last couple of years. So we have a concept such as a virtual fracture clinic. So not every patient with a suspected fracture now goes to an orthopedic fracture clinic. Often a history and examination findings are documented on one of the electronic record systems, and the radiographs are reviewed in a meeting, which just couldn't be more like, a radiology board meeting when you watch it and you hear the orthopedic surgeons complaining through it and think that actually this is my life, this is the amount of information I'm used to dealing with as a radiologist. So adding AI to these processes where we cannot possibly man them all with an MSK radiologist, I think is kind of vital to being able to continue the levels of throughput that we need with plain film. And the one other thing I'll say is, we are talking about fracture, but if we think about the rest of MSK plain film, there's only so much you can look at before you're bored out of your mind. And there are only so many times you can walk to the coffee machine and do a lap of the department. And actually think about reading knee x-rays, hip x-rays, grading osteoarthritis on them. There are so many use cases where AI can just come in and streamline what we're doing and take away some of the jobs that, if we're honest, we don't necessarily love in MSK radiology.
Very valid points. And so, you raised some very critical questions here, right? So you're talking about the lack of radiologists within the NHF and how everyone is maxed out. Some of the pain points that are seen not just in orthopedic surgery, not just in radiology, but also orthopedic surgery. And I know Jacob alluded to that with the ER physicians as well. So shifting gears a bit and going to the cost benefit perspective. So 2 questions on that. Even though it is fairly obvious that there is a cost to benefit advantage in having an AI solution to potentially automate all of that, do you foresee challenges when an AI solution is implemented within the workforce? And who essentially pays for this? And I know I want to hear this from both sides of the continent. So I'm going to begin with Jacob and Danielle, and then I want to have Jan's opinion in New York. So what are your guys' thoughts on the cost benefit perspective?
Yeah, so I think there is different perspectives, right? So when you go to just basic economic analysis, when talking about a cost effectiveness analysis, there is always different perspectives, right? So you have the hospital perspective, you have the insurance perspective, you have the societal perspective. So that's something we have to keep in mind. So talking about the hospital perspective, you need to make sure that you know what you're going to pay for, right? So if you increase quantity, that can be of interest. Of course, that's what we do it all for, right? Treating the patient in the most appropriate way. But we are not in a situation that allows us to just spend all the money that we can think of, right? We have to think of it and to use it in the most responsible way. So I'm saying that we have to have a look at the benefits versus the costs. And of course, you have a look at it at the hospital perspective, but also from a societal perspective. And then once again, it's important to not only consider, the short-term effects, but also long-term effects, because, AI could end up in diagnosing more fractures. But then the question is, those fractures that you are, basically detecting more, does that really affect patient outcomes in the sense of quality of life and so on and so forth? So summarizing, there is different perspectives, and it is important to take all the benefits and the costs into account and making it a responsible use of available resources.
Hey Jay, I'll try and give you some numbers for it if you like, that I can add to what Jacob said from the UK context. So our highest litigation fractures in the United Kingdom in order are scaphoid fracture, followed by occult fracture around the pelvis, including proximal femoral, followed by Lisfranc. Now, the average litigation cost in a missed scaphoid fracture is around £360,000. So what's that about? Getting on for $500,000, I think. I don't have monetary numbers for the others, but that's the kind of burden we're dealing with. We also have a figure that in our fracture clinics, 30% of attendees are falsely present with no fracture. So that's a very high, burden of pointless, expensive attendance in clogging up clinics. And so these are the kind of metrics that we use to persuade hospitals, not as radiology departments, but as hospital executives to invest in AI to try and reduce the burden of some of these figures. Now, I don't have data that shows we've reduced it yet, because we have these studies running to try and demonstrate this value. But these are the baseline metrics which we have started with and which we will demonstrate against at the end of our current running trials in my area.
Yeah, and how about the American perspective?
Yeah, so we're not using any in MSK any disease detection algorithms right now. I agree with everything that was said. It depends on your setting and where you practice and how you practice. We are very fortunate. We read 24/7 for all of our hospitals, and our lists are rarely ever behind, more than a few hours. So we don't have that situation where you have, x-rays piling up with, fractures in there that need to be pulled out. The opposite would certainly also still be helpful, if all normals would be sorted out. I think we have to go a step back, though. What we're right now doing is, pie in the sky wishful thinking. I think right now, none of what we're, expecting from AI has really been shown, or at least what I have seen conclusively. So I have not seen that it makes a radiologist substantially faster. I also have not seen that it makes a radiologist substantially more accurate. Now, I will agree, it depends on, your level of training and your level of experience and all that. But that needs to be shown first before we even talk about if we are buying and who is paying, right? The liability and the payment, questions are certainly very interesting, and I agree. It depends on who is actually benefiting from that. But I will tell you, if I go to my chair and say, I want a fracture detection algorithm, and there's several vendors out there, and we can sign here and buy it, he will say, I'll offset the cost through your section. That means you guys have to read more, assuming that there's an unlimited stream of studies. So for the radiologist, you see, if there's an additional cost. So if I have to read, 50 cases more in a day to offset the cost, then you will see that this will not, radiologists, will not be cheering for that. So, the insurance companies, they want to see this from a different perspective. What Daniel just said, they want to see the bigger impact, and then they may start paying. I think we're far away from that. So right now, I'm missing the data that really show where these algorithms improve and whom they benefit most.
Certainly. So missing the data, and to get that data, I think you have to step out of the reading room, step out of the dark room, and interact with the end users, the other folks that will be using it, right? The emergency physician, the orthopedic surgeon, the trauma surgeon, so on and so forth. I'm gonna, give a parable here. So Steve Jobs had this thing about the first computer. He had a handle on it, and for him, it was, yes, he can get into the computer and sort of explore everything, but there's one of the Apple engineers said that was also the reason why, if he didn't like what the computer was telling him, he could take the computer and chuck it out the window using that handle. So for him, having that control over the machine was really critical. And now, as we have this black box of AI, and we often are, uncertain about how it came to this diagnosis, and we have enough things on our plate where we're unable to actually devote the time to get the reason for why the output was what it was. How do we, get ownership, not just from radiologists, but from other folks, into the AI spectrum? And Kathy, I think this question is perfect for you because, you and your expertise as an AI researcher, AI scientist, how have you added, folks beyond radiology and across the healthcare system to be part of your efforts?
Well, I think this parallels when we started doing, 3D advanced post-processing, where it didn't really help the radiologist who does that innately in their head, but helped the surgeon or the referring clinician to see the 3D representation of imaging. But I think back to what Dr. Visser said, which was, it really depends on the perspective. So, anecdotally, as we were developing an automated, it happened to be a stroke detection model, we thought for the use for radiologists, we wanted to reorder the work list such that if there was potential stroke detected by the AI model, that would go to the top of the work list. And when we talked to the emergency room physicians, they said, no, 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 please tell us the no stroke so that we can clear the bed. So I think you have to get the perspective, and that is a very valuable piece for them to be able to clear the emergency room, or the A&E, I think, as you call it in UK. So I think the perspective is very, very important. I also think that some things may give you a value added in terms of maybe it's a study or a test that you don't do routinely that can now give you maybe as an assist, computer-aided decision support can bring you up to the level of a specialist, MSK radiologist, where you may not have that in your location. So I think, again, what's the perspective, and who, the results and the presentation of the results may be different based on whom you're trying to address. And so I think it's something that you really have to look at. And when you're developing models, you want to think about that. Before we do any model, we pair with clinical champions for all of our activities, and we do really interviews and surveys of all different types of clinicians, including radiologists, but others, to see, is this tool useful to you, and how and why, and what would you like to see in terms of how are the results presented to you. And sometimes there are parallels across specialties, and sometimes there are very specific asks based on whom they are.
Very interesting, very interesting. And you raised such good points, and to tie that back into what Jan said about the need for this solution, to whether or not this would actually make the radiologist more efficient, the work list better addressed. Well, I would say if you step out of the academic medical centers, right, in NYU, Southwestern, NHS, Harvard, when you're looking at folks that are delivering, critical care to folks that otherwise do not have subspecialty level interests, I'm thinking defense health, I'm thinking military, I'm thinking, small, even like small critical care, like rural areas that don't have any subspecialty things. I mean, that's where you can really tie in technical expertise with subspecialty level care without actually being on site. So there certainly makes a case for what can be done. One question that I had for Jacob, as we're moving towards the last third of the panel discussion, what do you see as the comprehensive AI use case as we move forward? And particularly, I'm getting a question from someone that I really respect and who's built some great things in teleradiology, is what, with AI being implemented within the teleradiology world, within the X-ray world, do you foresee more downstream utilization of cross-sectional imaging, including CTs and MRs?
Yeah, so I will come to that question, but I first would like to make and comment also on what Jan said. We talk about AI, but it's very important to keep in mind that we need a fundamental approach of this new technique, right? And now I'm referring also to the Freiberg model in 1991, which was published in the Medical Decision Making. And Mr. Freiberg, he introduced 6 levels of evidence before you basically can come to an introduction, an implementation of a diagnostic test in general in medicine, right? So he's talking about technical efficacy, diagnostic accuracy, diagnostic impact, therapeutic impact, patient outcomes, and cost effectiveness analysis. And I think we need to thoroughly study for each individual AI application according to these 6 levels from Freiberg, how does it affect patient care? And in order to do so, we need appropriate study designs. There is a very nice publication last year, or actually this year in radiology, that really urges, we have to take the appropriate study design, randomized control trials, parallel. You can of course have a discussion what's the good design, but we need good studies, good scientific evidence in order to know what's really valuable for a patient. And then please repeat your question, Ajay.
Well, I actually have another question on that. So since you talked about a good study, what does the ideal study look like for you that would convince you to go up to your hospital leadership and say, this is the AI factor tool that I need?
So I think that really depends on the situation. But it's very important to remember that if you want to have an effect estimation as precise as possible, then the randomized control trial is the most appropriate study design. And I'm not saying that you have to always carry that one out. You should have a look at the particular in the specific situation, but it's something to keep in mind.
For sure, for sure. And the second part of my question, and this is for everyone, is when you see AI being implemented clinically, right? Fracture, no fracture, and MSK pathology or no MSK pathology, do you foresee a downstream extra utilization of orthopedic interventions and potentially or cross-sectional studies? And I want to hear everyone's perspectives on that. We'll start with
Should I go first?
Please.
Well, actually, I'm hoping it has the opposite effect. I'm hoping that some of the occasions where, a more junior member of the orthopedic or emergency team who don't have the full confidence on a proximal femoral fracture and they're requesting CT or MR second line are actually given the confidence of the bounding box saying, 98% confident it is a fracture, and they don't need to do that second line imaging. And in fact, those are some of the studies that we're doing, because I'm in a center where we've used MR as second line imaging for scaphoid and occult hip fracture for the last 12 years. And so we've got a huge retrospective collection of X-ray and MR as ground truth to look back on.
Kathy.
I'd like to add, I agree. I'd love to see this not have to move to the more expensive and longer acquisition time and perhaps less availability. We've looked at detecting RA versus OA in a hand radiograph, and if we could do that, it's much more available. If we can do that at a level that is appropriate. And not have to go to other modalities and other tests, that would be even better than having to do some of the cross-sectional modalities. Of course, there's a lot more information in the cross-sectional modalities, but you don't want it. You don't want, maybe you call them incidental findings. I call them sometimes opportunistic screening, if you will, but sometimes those may lead to additional tests that you may prefer not to do.
Jan, what are your thoughts on the downstream effects?
Yeah.
More, better,
so I think we
worse?
don't know. So I think there's an area that there's very little known about. For example, if a vendor, if you purchase an AI algorithm, there's a balance between sensitivity and specificity. And we don't know for many of the algorithms, we don't even know where this balance is, So if you're a vendor, you probably want to be on the sensitivity side because you don't want to miss any fractures. When you think about it clinically, that's not what we're doing. X-ray is not a screening test. That would be the signature of high sensitivity. And that's what the studies have shown so far. And I want to put an exclamation mark behind that. We have to really think about that, what that means. It was mentioned in the comments, rightfully so, that some studies show that you increase the sensitivity to detect fractures. We need to go take a step back and understand what that means. That means that, yes, you may, detect more fractures, but it comes at a cost, and the cost is usually false positives. When you think about it, if you want to have 100% sensitivity, you call everything a fracture. and you're 100% sensitive. That drives everybody nuts. So if you talk about downstream effects, the question is how you're actually going to figure out what is a true positive and what's a false positive. And that may actually trigger a lot of things. It may also, if you really, play down, that somebody says, okay, the thing beeps the entire time. It drives me nuts. It drives everybody else nuts. So maybe it's not that great. So we don't know that. We don't know what the right balance is. For me as a radiologist, I want the thing to be as specific as possible. Of course, I want 100% accuracy, but we don't get that. Right? We're not 100% accurate either. But what people ask from us is specificity. If I say there's a fracture, there better be a fracture, right? Otherwise, the sensitivity screening has already been done. Somebody looked at the patient, somebody indicated the x-ray. Yes, we know there could be a fracture. That's our sensitivity screening, right? So I think we don't know that. I have asked many vendors, what's your balance, sensitivity, specificity? How have you figured that out? Nobody could really give an answer. I don't think vendors know that. Can I, adjust it? Can I, increase my specificity? And I don't want the thing to be very sensitive. We already have this in our system, right? And so on. So I think we don't know. It depends on a lot of factors. I think we always assume the absolute optimal case of what AI can do for us and how it would solve our problems. But we know very little about it, and it may go the other way. It may do absolutely nothing.
It may do absolutely nothing, or it could actually do worse. And you're right. There's so many unknowns that we know that we do not know about. That's why they're unknowns. But I think if you look at history, what history has shown us about CAD in mammography was that for which vendor you looked at, you had a 4:1 rate of overcalling. Calling when there was diagnosing pathology when there actually was no pathology. Did it lead to overutilization? Did it lead to more imaging? Yes. Did it lead to extra costs? Yes. Some could argue that 15, 20 years ago, the technology wasn't as well developed, but looking at the specificity and sensitivity are very critical and important points. I mean, I particularly get a little bit alarmed when a vendor comes up to me and says, "Oh, an AUC of 0.99 or 0.95." I'm like, "Whoa, okay." Everything else was going well, but then you dropped that bomb. So that's no bueno. So we're getting to the last part of it, audience. For every single person that's here, please feel free to add in questions. One last quick question that I have for the panel. So if you were to draw a 2x2 matrix going into the future, the best case scenario, worst case scenario for AI in radiology centered around MSK, what is it? We'll begin with Jan again.
Well, best case scenario is that we would manage to implement those gainfully and sleek, like in a good way in our workflow, and it would make us more accurate and faster, and we would show actually impact on care, that it would overall improve outcomes and decrease costs. That would be the absolute best scenario, I think. Or one very good scenario. The worst would be that it is like bloatware. It makes your system bigger, more expensive, slower, and it may actually wash down your outcomes and your care. And I think we have seen this with it's intrinsic to big systems. The bigger they get, the more complex they get, the harder it is for them to perform. We know this from very big companies. There's just I don't know, a pen ends up costing $80 at some point when it's really, you can buy it around the corner for $1. So I think that's the danger I see. So I think we have to be very careful. And like I said, good, like was said before, very good design studies that are practical. And I think those are missing right now.
Definitely. Dan, best case, worst case, AI and MSK.
Well, the best case is that everything's awesome. It works really well and takes away the boring work that we don't enjoy anyway. However, I think that right now there are some big questions. Was the current crop of AI trained on me on my best day, my bored day, or one of my worst days? Because ground truth at the moment is radiologist reads and not, like I've talked about, kind of gold standard cross-sectional imaging or other ground truths. I once posted a somewhat cynical tweet, which could be the dystopian way that AI ends, which is I predicted that there could be a day where it's AI for the poor and doctors for the rich. And with health economies, particularly in a system like mine, which is overstretched, I do wonder if the health economists and executives think that that might be a direction that we could go.
I like it. Yeah. I certainly like the slight dig to the hospital administration. Always sticking to that. So that's good. Jacob, best case, worst case for AI and MSK.
Yeah, so I would a little elaborate a little bit more on what Dan just mentioned, right? It could also, in the best case scenario, it could enhance access to healthcare for anybody, right? So that would definitely be my ideal situation, that people who are not going to have access at all, for example, to chest X-ray, that you can use, tuberculosis screening, that you now basically go down there, have an algorithm, and let it check for particular diseases, for example, TB. So that I think AI could, in the ideal situation, add to the equality, even globally. So access to healthcare, that would be my most optimal situation. What can be the worst case situation is that, that there is plenty of vendors. They come in with all innovative stuff and we just implement it. We make the healthcare as expensive as possible without doing any research and just taking it as, this should be good because it's AI. That would be my worst case scenario.
Very true. Last but certainly not least, Kathy, best case, worst case, AI and MSK and just AI in general.
Yeah, Jacob said it to me. I was going to sort of turn it upside down to what Dan said. And, I'm hopeful that we can give high quality care. We're used to being in an academic healthcare center. We're real snobs. We have access to wonderful care, but not everybody does. I mean, I understand in Africa, there are thousands and thousands of miles where there's one radiologist serving that country or that region. So can we give high quality care to people who currently don't have it? The other piece, I think, is can we bring people? We also have specialists. You all are specialty radiologists. Not everyone is. And can we bring the quality of care up by using these technologies? So I think the worst case scenario is that we sort of blindly implement these technologies without thinking about, what is the clinical question we're trying to solve? Do you have something you're trying to solve? And choose something that solves that particular problem, and then implementing it in the proper way. It's not just the technology, but it's the people in the process. If you implement it in a way that it is an annoyance, or there are bells and whistles going off all the time, or the sensitivity is too high, you can change that operating point to make it a tool that is useful for you. But that takes a lot of work, and very little people are working on that implementation piece right now. And I think that's something that we need to do. And after that comes, so what? The impact piece. And we've done a horrible job of that so far. So those would be my pluses and my worries for the future, that people will blindly accept these tools.
Excellent points all around. I'm seeing a lot of audience questions coming up. I'm going to give it one more minute for the rest of the audience to add in as many questions as possible. And then one final question for the panel. Are you using any AI products in daily life that's making your life easier? It's centered to Dan, but everyone is welcome to answer.
Yes, I'm probably at the kind of far right of adoption of the curve. And, everyone's been playing with ChatGPT, marveling at what it comes out with. But, I'm doing a study to see if we can summarize our technical radiology reports into a nice patient interpretable report at the moment. And that's looking really good. But, in my personal life, if my code isn't working, I throw it into ChatGPT or GitHub Copilot, and it is amazing what it comes up with. I literally copy and paste it back out of there, and it works. And so that for me as a side gig coder is magical. And it's in times when I just had to stop and give up before, I'm able to achieve things now. So I think that's my favorite use case for it.
Very cool. Very cool. Coders listening in, don't worry, your jobs are not being replaced. You still have a great career and future ahead. So all will be good. All right. Opening it up to the audience. So I'm going to scroll down from the top. How important is it to detect and diagnose stress fracture happening due to osteoporosis and other abnormalities? Do we see such cases very frequently in the ER? So I'll just take that. So yes, we do see stress fractures quite a bit, and yes, they stress. The definition of stress fracture is abnormal stress on normal bone. There's too much stress on otherwise normal bone. So does it come from the ER? Often, yes, it does. Usually if you're lucky, the history is good enough that it kind of leads you to that finding. Or if you're able to pull it up from the EMR, you're able to kind of see what's going on. So I would say of the cases in the ER, it's not an overwhelming minority, but a sizable minority. Jan, Jacob, Dan, feel free to agree.
Yeah, I agree. I think it brings up an important point, right? So the task that radiologists do, or that a radiologist does, is not just detection. My orthopedic surgeons sometimes tell me, I can see that. Thanks. I want you to characterize it and tell me, how old is this? What is the etiology? Can you even make a prognosis? So what the question goes there, right? So it's not a traumatic fracture, it's a stress fracture. That would be also something where the AI algorithms need to ramp up their game a little bit. Often they're binary, fracture, no fracture. And then somebody, like Dan said, the human is the tiebreaker because they'll learn from human. But it is in MR, right? Meniscus tear, yes, no. Well, is it medial or lateral? And then what type is it, right? Is it degenerative? Is it acute? And what configuration does it have? What's the tissue quality? And so on. So there's a lot more to that than just saying, oh, yeah, it's there. So that's a good question, right? So there's different things to look at, not just whether something is there in a binary fashion.
Very true. Very true. Yes, Dan.
I think AI fracture detection is going to really struggle with stress fractures because by nature many of them are not displaced, and we only detect them on plain film at the point that we start to see a sclerotic band or callus formation in the healing stage. And so I think it will still struggle to see them unless they displace or they're healing. Osteoporotic was mentioned, and that's another use case. I have seen in use vertebral fracture detection algorithms on studies intended for other purposes. So an abdominal CT, chest CT, picking up these incidental fractures or indeed just morphology corresponding to osteoporosis. And if you remember at the beginning, I said I'm very interested in population scale AI, and I think that is a great use case to kind of side read studies, detect other conditions, and be able to initiate a public health intervention to improve bone health.
Perfect. I mean, if we struggle as radiologists with particularly characterizing stress factors, I mean, it's also, it would be asking too much for a machine to automate it when our clinical definitions are a little bit off. So, no, great points. 30% is a very high number. Dan, clogging up clinics, a quick abnormal normal can help reduce this burden via AI. So that's maybe where the binary use case of AI would make sense. Is AI able to detect, and Dan responded to that. Rajesh has a question. Is AI able to detect the typical fracture? Sorry, my thing just keeps scrolling. The typical fractures like occult and subtle. So, it all depends. In studies that have happened, they've said that, in the most recent meta-analysis that came about, it said that the human was able to detect some of the more occult fractures, but AI wasn't able to do it, and AI sometimes missed. AI was able to pick up some of the more obvious fractures that the human missed. So, occult is, you could argue is still not a well-defined term to say what's fracture or not, because in hindsight, everything is obvious and it wouldn't be. So, it all depends. But usually AI is, able to detect both occult and obvious fractures, but, sometimes it's not. The next question was, what, according to you, are the good use cases for AI? Are there some areas that need more attention but are neglected right now? Question for everyone.
I think the answer is yes. Yes.
How about protocol?
Yeah. Kathy got it right at the beginning. Actually, it's pre-acquisition.
Yeah.
So it's protocoling. It's actually passing the clinical details provided to direct the study into the right test before we even do it. I actually think one of the least exciting use cases is interpreting the images, and there are so many places that it could help us as radiologists in the administrative side of our jobs and the accuracy side of our jobs that I'd like to see some investment in.
For sure. What are your thoughts on Oh, sorry, Kathy, go ahead.
Sorry, I was just going to say, who loves doing a bone age study? That's something that is sort of the hello world for AI. And, that's something that many people have created models for, but also something like looking at low back pain, looking at MR of the lumbar spine. That may not be a challenging detection piece where you're labeling the spine. It's tedious. You have to report on every vertebral level, and is there stenosis left, right, centrally, and so on. That's a workflow issue. So again, like Dan is saying, I think there's so many things that can be done to improve the efficiency, like other businesses outside of healthcare have gotten from these technologies.
Agreed. What are your thoughts on DICOM AI results being auto-forwarded into the PACS? Is gating the accept-reject of AI results necessary at your institution?
I'm not so sure what gating the results really means. I mean, the typical workflow we're talking about is that a study fits some sort of automation rule, and it's moved to the AI machine to be interpreted, and then the secondary capture is sent back to the same kind of study packet, and it sits alongside the unaffected original. But I'm not sure what gating means, if anybody else perhaps knows.
Yeah, so probably it comes down to the fact that when a study has been processed by an algorithm, and you do not, for example, agree on the findings, on the results of the algorithm, are you allowing that results, getting them into the PACS? And that may be relevant for some use cases, because I have also personal experience in our institution that there was some AI results ending up in the PACS that were not there in the radiology report because the reporting radiologist didn't agree, with the AI findings. But then there was emails and phone calls. Okay, but there is in the PACS, there is a nodule, but you were saying it's no nodule. So what's right? So I could see a role of gatekeeping with that respect.
For sure. And the other dichotomy that comes up is, are we gatekeeping to our referrers, or are we gatekeeping, when it goes into the report, is it going out straight to the patient? We can't let, undocumented, unfiltered images or unfiltered results get straight to the patient, or can we in the near future if we agree? So plenty to think about. Do you think osteoporosis can be a good case for AI MSK, especially osteoporotic fractures that occur at the spine, hip, distal forearm, and proximal humerus? Apart from the obvious yes, is there anything else that anyone else would want to add?
I think we went over it, didn't we? And I think we all agree that detecting these things incidentally, particularly on other studies, would be very beneficial. I mean, there's probably also a role in automated analysis of DEXA studies as well. I think that would be a very easy target for AI.
Yeah, and just to give a little Oh, sorry, Kathy, go ahead.
I'm sorry. I agree. I agree completely. I think these sort of opportunistic findings in, say, an abdominal CT, you can be looking at, bone density measures from CT and maybe, not have to do the DEXA, or you could look at frailty, sarcopenia and so on, which, as we queried our referring clinicians, it's of importance to all kinds of clinicians, whether they be a surgeon, oncologist, endocrine, so on and so forth. So I think there's some things that are very, very important that we're not reporting, certainly in a quantitative fashion, because it's very difficult to do for a human being and time consuming. So I think these are low hanging fruit that could become value added to your radiology reports.
For sure, for sure. And as you all know, osteoporosis clinical definition goes to DEXA, and all of us read hundreds of X-rays a day, and we can't really diagnose someone with osteoporosis or osteopenia, whether we want to or not. So having an AI tool that can particularly gate you in that diagnosis would certainly be helpful. But again, the devil is in the details, right? Wondering about your thoughts on AI for pediatric MSK radiology. Might be a completely different technology to build, but does it have the same pressing requirements and scale as adult MSK radiology?
Most of the AI fracture companies so far have avoided training on pediatric data sets. I've tried pretty much every market available fracture solution at this stage, and I haven't yet seen one that is licensed to work on pediatrics, but several have it close to production. Of course, it's a good use case, because these are some of the fractures which emergency physicians, orthopedic junior doctors struggle with the most, because they're not familiar with looking at pediatric studies. Even in radiology, people struggle with those more than adults. So I think it would be a useful assist.
Absolutely agree. I think the pediatrics use case across the board, and particularly within peds MSK, has not, that area has not been addressed as well as it should have been. So I completely agree that we need to have that within the market as soon as possible. Someone by the name of Dr. Just says, I can show you how I leveraged OpenAI and ChatGPT and write a full scientific article about how radiologists can increase confidence in MSK MRI. And that's at Dan. So maybe it's only for you, Dan, but if Doctor wanted to give us more details about themselves, we would like to know about how to do that. Question from Ankit. How is AI for poor a dystopian scenario when currently there are countries, programs without access to any radiology expertise? Isn't AI better than having nothing?
I think I have to address my former comments, don't I? I think I was coming at it from the other end of the spectrum, which is, we're all on this panel, we're all in countries where we've got kind of comprehensive healthcare systems. Mine, universal and free at the point of access, others funded in a different way. But if we ever ended up with a system where either the insurance company or the health service were rationing access to radiologist interpretation of certain studies, and that some people only got an AI interpretation, well, that's a retrograde step to where we are now, only in the name of health economics. However, as was pointed out, if your starting point is not what we have now on this panel, and if it's no access to any interpretation, clearly that's an improvement.
Definitely. And Ankit, so what we're just referring to is standard of care. Want to get a basic standard of care, and anything above is great. So what you don't want is limitation standard of care. Dan so eloquently summarized. Last question from Murad now. What are your thoughts on importance of clinical data and diagnostics? It is a key data point that human readers have access to against AI, or how much does it contribute to decision making?
Yeah, so maybe I can give a shot on that one, because we are radiologists, right? And radiologist means that you are a medical doctor, and we shouldn't forget that. We are not just image interpreters. So we should have a look at the patient in total. taking into account other clinical data as well. So, for example, if you have a negative result on an AI algorithm, for example, for cervical spine fracture, you could say, okay, the sensitivity of this algorithm is not, as strong as I would it have to be. But given the fact that there is no pain, given the fact, that there is no, that there is no complaints for the patient, we could say, okay, let's discharge the patient to the hospital. So combining AI results with other clinical data, I think it's important.
Certainly, certainly. Perfect. I think we're at the end of our audience questions, and we're slightly over our time. So with that, I'd like to conclude our panel. Not to sound like a utopian tech bro, but AI will make things better, right? So now it's just a question of how we can put all of these collective brilliant minds, and I'm not just talking about the panelists, but also every single one of you that was joining in to listen to us, prognosticate, diagnose, how we're going to implement new technology within medicine, within healthcare, within MSK, and particularly within MSK X-rays, and how we can actually make an impact. And I think having that interaction between all these multidisciplinary fields, academic centers, private practices, teleradiologists, defense health, folks in the US, folks in the UK, folks in Europe, folks across the world, this is how innovation happens, and this is how it would lead to great things. I want to give a quick word of gratitude to Qure for bringing all of this together, particularly Ruchi, Dhruv, Rohit, and their entire team. And we're very excited to see next steps. And particularly the biggest gratitude to Jan's cat for, upstaging all of us, man. Well done. Well done. All right, guys. Thank you so much.
Bye.
Great chatting with everyone. Thank you, audience.
Thank you.